Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
All right. So I welcome everyone for the class tonight. We have a case on breach today, and Shreya is the presenter. She's been kind enough to present this difficult, I would say, not so easy a case. Why? Because a lot of counseling, a lot of statistics, and a lot of maneuvers are involved while discussing this case. And why breach is difficult? Why am I saying that? Is because breach case, if you fumble in breach, people will not pardon you because breach you've been studying right from your undergraduate level. So certain cases which seemingly are very easy to take, but if you fumble in those, you can have a lot of negative points. So be very, very careful with the simple cases like normal ANC or a normal puparium or breach, because these are very simple cases and you can be marked very badly negative if you're not able to answer some basic questions or fumble in the basic questions. All right. So with this background, let's start tonight's the case today. And yeah, Shreya, we can start now.
Okay, ma'am. Starting a case of breech presentation. Here is my patient named Mrs. X, 33 years female, residence of Sri Sai Nagar, Kachikali, Bangalore, housewife by occupation, studied till MBA, wife of Mr. X, doing private job, belonging to upper middle class by modified Kupuswamy classification. Date of admission was on 10th of May 2024. Last menstrual period on 23rd of August 2023. Expected date of delivery 30th of May 2024. Period of gestation is 37 weeks and obstetric score is Gravida 2 Para 1 Live 1. Chief complaints. Gravida 2 Para 1 Live 1 with 9 months of amenorrhea was called for external cephalic version. No complaint of pain abdomen, PV leaking or PV bleeding.
Okay.
First trimester.
Yeah, is this history, no complaint of pain, abdomen, leaking, bleeding, specifically important in your case? Otherwise, of
Yes,
course,
ma'am.
we obviously ask, but why is it specifically important in your case?
Ma'am, it is specifically important in my case because I am calling my patient for external cephalic version. And if in case she's having any pain, abdomen, leaking or bleeding, I will not do the procedure.
Yeah, these are the contraindications for ECV. So it's very specifically important in your case. Okay, go on.
Then first trimester, uneventful. Second trimester, uneventful. Third trimester.
Shreya, let me tell you that. Let me tell everybody, when you're presenting a case, you've reached to the obstetric history, until unless the examiner stops you from speaking the entire obstetric history, you will speak the history, right? You've written it down and you're speaking right now. I can see slides, but examiner does not know what's there. You don't share your written history with them, do you? Right?
No,
so what
ma'am.
you're speaking is what finally, it's uneventful. They can stop you, they can ask you, your mood will be upset, So it's always right to just keep speaking. The first trimester, it was a spontaneous, let them interrupt. Let them say, okay, I don't want to hear anything specific in your first trimester history, okay? So was there anything specific in your second trimester?
No, ma'am, it was not specific.
Okay, and was there any reason that you got to find why was this a breech baby? The previous one was breech, or was it a normal cephalic baby?
Normal delivery, ma'am.
Okay, so was there any reason that you found out why was it a breech baby?
No, ma'am.
Placenta lower could be one reason, right?
No.
Lower.
Yes, ma'am. It was, but the placenta was not lower, ma'am, in this patient.
Okay, so it was not. All right. So with this, can you tell me the etiology of breech?
Yes, ma'am. The causes of breech can be either maternal, fetal, or placental causes. In maternal causes, it can be due to breech. It is due to multiparity, ma'am. Multiparity will lead to very lax abdominal wall.
Yes.
Am I audible, ma'am?
Yes. I can hear you. Guys, you can also hear her, right? If anybody has any glitch, please, guys, if you can't see the slides properly, if you cannot hear properly, I would like you all to interrupt, write it down in the chat box so that I can immediately take action, right? So the recording also goes now. It doesn't look good that my students are not able to hear or see the slides properly. Just let us know. Yeah, please continue.
Ma'am, causes of breech, maternal causes can be multiparity. It will lead to lax abdominal wall and more prone for the breech. Then contracted pelvis, any uterine anomaly, bicornuate, septate uterus, uterine delphus or unicornuate. maternal obesity, and placenta previa, low-lying placenta, abnormalities of Liker, ma'am, poly
Yes.
or oligo, or previous history of breech pregnancy. If 1, then the risk is 10%. If 3, then the risk is 29%, according to Williams, ma'am.
Okay. And if what is the de novo occurrence of breech? What is the incidence of breech? De novo.
Ma'am, incidence of breech at term is 3 to 4%.
Yes, correct.
And
Okay.
fetal factors for the
Yeah, fetal factors.
fetal factors can be prematurity, most common cause, low birth weight, multifetal pregnancy, any fetal anomalies like anencephaly, hydrocephalus, yet trisomy 13, 18, 21, or short
Yes.
umbilical cord.
Yes, correct. Okay.
And placental causes, placenta previa, cornofundal attachment of placenta. It can be the cause, placental causes, ma'am.
All right. So these were the etiology, and we didn't find any such thing like prematurity or some biconvert uterus, low-lying placenta, oligo or poly. Nothing was found, right? So it was just a de novo breech, most probably. Yes. And you called her at 37 weeks for ECG.
37, ma'am.
Okay, all right. Just like that, over here, though your obstetric history is yet to come, her previous one was a normal delivery. She's not a cesarean, right?
Yes, ma'am. Previous one was a normal delivery.
And that was everything was normal in that.
Yes, ma'am. Everything was normal.
Okay. Now, you have called her at 37 weeks. What is usually the correct time for calling a second gravida and a primary gravida, both for ECV? What gestation?
Ma'am, for ECV, we call nulliparous at primary gravida at 37 weeks and multiparous women at 37 weeks.
Okay, and the reason is?
Ma'am, the reasons are because the spontaneous conversion of breech after the term is very less. Spontaneous conversion of breech can occur till term. And second thing is, if any complication occur during external cephalic version, we can immediately take up the patient for emergency cesarean section. And even if we are successful after doing ECV, if we have converted into cephalic, then the chances of reverting back to breech is very less.
Okay, okay. What I mean to say is, why primary at 36, why multi at 37, why not both at 37 or both at 36? That's my question.
Ma'am, because primary has very tight abdominal wall.
Yeah, yeah. So you'll call her at that time when her Liker is more, right? 36 and
Yes,
37,
ma'am.
the only difference usually is that by 37 weeks, we see that the Liker becomes a little less and the fetal weight increases a little more. Though in 1 week, there'll be hardly any 10, 20 grams difference. But Liker makes a lot of difference. You will see that yourself. You must have seen it, in fact, yourself. Certain patients, 36 to 37, the Liker differs a lot, okay? Plus, with the tone,
Yes,
it
ma'am.
becomes easier. Yeah, it becomes easier if you have more Liker around. So the chances of ECV, successful ECV, are a little more as seen by the studies in 36 weeks for a primary and for 37 for a second gravida, third or fourth, whatever, multi-gravida, correct? All
Yes,
right.
ma'am.
So now, because we're talking about the success chances, let us know the predictors for a successful ECV, and then we'll talk about the scoring.
Ma'am, predictors for the successful ECV is one, an experienced obstetrician, ma'am.
Okay.
Then 24/7 OT facility should be available around the clock.
Yeah, but that's not exactly the chances of success of ECV. I mean, looking at the patient and the fetus characteristics, tell me what are the good characteristics in the mother and the baby, so that the
For the
ECV is
factors which will enhance the success, ma'am.
yes predictors of
Yes,
success.
ma'am. Ma'am, it is multiparity, non-engaged presenting part, flexed
Yes.
breech, adequate Liker, and non-anterior placenta.
Okay. Yeah, it should not be, preferably it should be posterior because that will increase the chance. There are certain more, maybe a maternal weight of 65 or less that increases the chances. And yes, you can still speak an experienced obstetrician because that will help us, that will increase the chance of a successful ECV, correct? Okay.
Yes,
So
ma'am.
that was the chances of ECV being, how will you take up the patient for ECV? What are the prerequisites? I mean, what will you do before? Taking her up for ECV.
Ma'am, before taking up the patient for ECV, first we'll explain the patient the procedure ECV, that it is a safe and a successful procedure with less complication rate and a success rate of 40 to 60%.
Okay.
will also tell us there is also a chance that ECV might fail and she has to go for the cesarean section.
Yes. Emergency
And
cesarean section, right?
yes, ma'am,
So let
emergency cesarean
me
section.
yeah. Do you have the percentage of what is the chance of an emergency cesarean section in while doing a breech?
Yes, ma'am, the risk of
I'm
emergency cesarean
considering
section is 0.5%.
correct, correct. And if suppose you were planning a proper vaginal breech delivery, not ECV, then what are the chances of emergency cesarean section while you were taking a breech trial?
Ma'am, when we are taking a breech trial,
Yes, you're giving a breech
successful,
normal delivery. Yeah. No, 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 not successful. Emergency cesarean section chances when you're giving a breech delivery, a proper vaginal breech trial.
ma'am, then also the risk is
Very high.
0.5% only.
No, 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 no. It's very high. If you're giving a chance for a vaginal breech delivery, the chance of emergency cesarean section reaches up to 40%. Up to
Okay, ma'am.
40%. Okay. And
Okay, ma'am.
otherwise, we'll discuss it later. But for a breech trial, yes, planned breech, vaginal breech trial, it is as high as 40%. But once you do ECV and emergency cesarean section and during ECV, that's just 0.5%. So it's pretty, manageable. Patient will be counseled pro ECV. Correct?
Yes,
What
ma'am.
else? You counseled the patient. What else?
Ma'am, we'll counsel the patient regarding there can be ma'am, there can be chances of cord prolapse also, ma'am. There can be rupture of membrane. There can be chances of cord
Yes, yes,
prolapse.
yes. CTG going deranged, cord prolapse. But it's better not to speak. We can always speak rupture of membranes, right? Cord prolapse
Okay,
will
ma'am.
not be, don't use this term of cord prolapse, just say rupture of membranes or a patient going in preterm labor, CTG going deranged, or, non-reassuring CTG, or frank suspicious CTG, pathological CTG, that can also happen. So fetal distress basically can happen during ECP. Then even after ECV, it can revert back. There are also good chances. Okay, guys, since we're talking a lot about percentages over here, let me tell you one thing. Suppose you're not able to speak a percentage in exam. Okay, examiner is asking you a lot of percentages and you're not able to speak percentages in exam. Do not worry. At your level, you are not expected to know and remember the percentages for everything. And if you're fumbling in percentages, please don't mind it too much. But there are certain important percentages which we are discussing in this class, which are important in counseling. Like we just told you, 2 percentages are only important when you're talking about counseling for ECP, right? Which we just said, 0.5%, 40%. Okay. ECV, because you're talking about ECV, this question is definitely going to be asked: what is the success rate of ECV, and how will you counsel the patients? What are the chances of emergency cesarean section in ECV? And 2-3 other important percentages which we will discuss in the class, which are important to be remembered in the exam. Otherwise, apart from these percentages, do not worry if you're not able to answer. Okay. And even these percentages, if you fumble, again, don't worry. You will not be failed because of this particular part. Right? That was my intention of telling. So yeah,